Underdahl was recommended to speak this year at winter clinics by no less than half a dozen people, so we're excited to hear her 90-minute presentation on prescribing menopausal hormone therapy with confidence. Hannah is a women's health nurse practitioner and a certified nurse midwife who was born in Canada and raised on the coast of Maine. After college in Colorado and graduate school in Washington, D.C., she settled in Boise with her husband because of her love for the Idaho sawtooths, which she had backpacked in her early teens. She worked for over 3 years in a freestanding birth center in Boise before moving into a faculty role at Full Circle Health in 2016. Having now stepped away from obstetrics, Hannah specializes in female sexual dysfunction, pelvic pain, and menopause. She is certified through the Menopause Society and has completed extensive additional training in the intricacies of menopausal and perimenopausal care. Hannah stays active in professional organizations and advocacy groups, including the International Society for the Study of Women's Sexual Health and the Idaho Cluster for the Reproductive Health Access Project. In her free time, she travels with her husband and 3 small children in a Sprinter van they built out. She's an avid trail runner, mountain biker, and skier. Please welcome Hannah Underdahl.
So before I even begin, I just wanted to thank ACMS for the lineup of talks at this event. It's pretty impressive. It really shows a commitment to preventive health and actual care for patients. So I'm really excited about all of the talks. And then I wanted to just have a moment of pause. There's a lot going on in the world right now. There's a lot of uncertainty, a lot of hatred, a lot of confusion. And I wanted everyone to kind of look around the room at their colleagues and where we are and just give a moment of appreciation for all of the really hard work everyone in this room is doing. There are people in this room who are tirelessly advocating for reproductive justice in the state and nationally. There are people who are trying to save the WHAMI program in this room. And so not only are we here to learn, but I want us to really appreciate like how hard outside of this stuff we are all working right now, because this is not an easy time or weekend to like show up for something like this in addition to everything else you're doing. It's not an easy time at all right now. So thank you for being here. Thank you for caring about your patients and caring about learning. But today we get to talk about menopause. I'm obsessed with menopause. I see a lot of familiar faces. I work with several people in this room, so a lot of you have already heard a version of my education on this topic, but this is like so far what you've heard on steroids. How many people in this room feel like they already have received a decent education on the menopausal transition and how to prescribe menopausal hormone therapy? So a whopping 4, maybe? Okay. And then how many people actually already do prescribe menopausal hormone therapy? Oh, look at this. We're up to 16. Okay. Is there anyone in this room who currently harbors some like confusion, maybe a little bit of fear or hesitancy around doing this? Great, 11 and a half. Well, okay, so it's not your fault that you might be hesitant to do this. If anybody trained after July of 2002, when the Women's Health Initiative press conference was held, this was intentionally stripped from medical curricula. So not only how to prescribe menopausal hormone therapy, but what is the menopausal transition, what areas of the body does it affect, and what we need to be aware of. That was all completely taken out of your curriculum. So it's not like you slept through those classes. They were never offered to you. So not your fault. And then an important thing to go into talk about right before we start is that no medical specialty owns this. You think maybe OB/GYN. They take care of women and only women, and we'll talk about terminology in just a sec. They don't. We'll get into like the percentage of OB/GYN curricula that require including this. Maybe endocrinology, hormones, I don't know. Nope. Family medicine, it's not required. So I urge you today to think about beginning to do this, whether you work in psychiatry, family med, just think about where this could be applicable to your practice because nobody else is doing it. Disclosures, I think the most important one on here is that terminology around this topic is a little vague. When I use the words women, woman, I'm talking about people who are biologically born with ovaries, but I recognize that those terms do not adequately represent all people who go through this life transition. So I ask for some grace with the use of the terminology during this. And the next really important one is probably the last one. Yeah, yes, no one pays me for these products or anything. The last one, I am going to talk about some off-label use, which if you remember and you think about what you did in clinic this last week, we use medications off-label all the time. Okay, so learning objectives, blah, 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 blah. Basically, by the end of this, I want you to have applicable tools to take to clinic next week or take to your practice next week to know how to do some of this stuff. I call it a Monday morning launch program. That's how I lecture. That's how I teach. It's actual action items that you guys can use immediately. Okay, so what this lecture is not. So if anyone was at the IAFP, was it IAFP last May? There was a lecture on kind of rehashing the Women's Health Initiative and where it went wrong and why it was so harmful. I'm not going to get into that today. I'm not going to insult your intelligence. We are over that. That whole topic does not deserve our time anymore. We need to get into how do we actually help people. So I'm not going to go into that or field questions specifically on that today. If this is not going to be a comprehensive, what is the menopausal transition? What areas of the body does it affect? Again, not going to insult your intelligence. We've already hopefully learned all of that. Not a lot of basics in here. We're going to get into the nitty gritty of how to do this. What does the actual evidence say? And what can you do next week? Ooh, one back. I don't even need to go into this comprehensive guide of high-risk things because we're starting kind of low here on risk. So everything I'm talking about today is like best case scenario, lowest risk scenario. These are additional lectures and still great candidates for menopausal hormone therapy in those high-risk categories, but we're not going to go into that today. Okay, so I'm going to tell you how. So, but first, it's really important that we are all in the same mindset here, in the same headspace. In order to learn, in order to improve practice, we have to be willing to be wrong. And that means that we might not be wrong, but you have to present every learning opportunity saying, I might be wrong, my preconceived notions or opinions might not be correct. There's this great book called Think Again from 2021. In which Adam Grant talks about 4 types of thinkers: the preachers who try to persuade, the prosecutors who really stand inflexibly and try to convince, politicians, they just want to please everybody, and then there's the scientists, and these are people who really prioritize the truth and the research over their personal beliefs and biases and maybe preconceived notions. And the goal here is with the mindset of growth. And so I really urge you to adopt the mindset of a scientist during this presentation and maybe kind of put aside the fears and maybe bad habits we have around menopausal transition and hormones and stay open-minded. Okay, so why do you need to know this stuff? Do you know any women? Do you like women? I don't know. This is a universal experience. Every single person born with ovaries will go through this life transition. Rough average age is about 51 in the United States. This isn't diabetes, it's not obesity, it's not cancer, this is more common. And yes, it is not, well, there's a lot of debate whether or not it's a disease state or not, and I could get into that talk too. But it's important to know that almost 10% of women go through this transition, begin it, before the age of 45. It's probably younger than you thought. Women who lose their hormones sooner have higher risks of diseases. The transition can last a decade or more. So this isn't a couple of months. It's not required in all OBGYN curricula. And typically we think of OBGYNs as the ones who own women's healthcare for the most part. If all you care about is money, there's a bullet point on money, 1.8 billion lost in missed work days and debilitating symptoms. And we now know that the earlier we initiate menopausal hormone therapy for appropriate candidates, the better the outcomes. So the clock is ticking. So it's 23 years-ish since the Women's Health Initiative. In July, it'll be 23 years since that press conference came out, which was not even a complete evaluation of the data. Now we know a lot more than we did then, but a lot of the research that is done is actually on that initial data set because it was humongous. It was the biggest study that we will ever have on people taking menopausal hormone therapy. But if at this point, if today on the 28th of February, 2005. If you're still not convinced that the benefits may outweigh the risk, I'm just going to point out some great numbers here for you, big bangers. We know there's a 30% reduction in all-cause mortality when this is given to appropriate candidates at the right time, up to 50% reduction in coronary heart disease. We add lifestyle medicine and hormonal replacement therapy for appropriate candidates, and we can take over the world. These are the two articles. The article on the right is the one that was highlighted in the lecture at IAFP, if you were at that. But these are two great articles from 2022 and 2024 that really go over like the nitty gritty of why these keep people alive. Okay, so does everybody need it? No, but everyone deserves a really honest discussion on their individual risks, benefits, and alternatives. And we need to stop gatekeeping these medications and saying, oh, you had a blood clot when you were on a birth control pill when you were 23, you can't have hormones. Or you're a breast cancer survivor, you can't have hormones. This needs to be more of a discussion because now we know all of these benefits and women should decide for themselves. I mean, statistically, most ovary owners are going to die of cardiovascular disease. Like that's what kills most of them. And so they should be able to decide what thing they die of, basically. The NAM's position statement from 2022 on hormonal replacement therapy is actually very conservative. I point you to it because this is the national certifying organization, but they are very conservative. So I'm going to talk about things today that are even more up to date and more accurate than even their position statement. Okay, still not convinced? Let's do it in visuals. Okay, so this data came out of the Women's Health Initiative, but this actual study was published in 2016 by Manson et al. And everything, oh, it barely works. Everything below the x-axis is a decreased risk, okay? Everything red is an increased risk. So conjugated equine estrogen is the estrogen synthetic that was used in the Women's Health Initiative. We now know it's pro-inflammatory on cardiovascular. MPA is medroxyprogesterone acetate, the synthetic progestogen that was used in the Women's Health Initiative. In the arm of folks that took only conjugated equine estrogen, we saw huge benefits. Look at this, diabetes, nobody talks about that. All cancers, woo! Where's the all-cause mortality? Right? Death from any cause, there we go. And when we add in MPA, we didn't see quite as many benefits, but it's still pretty impressive. We're not entirely sure, but we do know now that MPA does have an increased risk of breast cancer. It is inflammatory on breast tissue. So these are not the mainstay anymore of hormone replacement therapy. Okay, so what is the menopausal transition? I talk about this transition. We need to start focusing more on what happens in this entire transition versus like what happens on the 365th day after you've had any uterine bleeding. Like nothing happens that's the diagnosis of menopause. 1 full year of no uterine bleeding in the absence of an ablation, an indwelling IUD, a hysterectomy. There's nothing special about that one day, but we focus so much on like, does this person meet criteria for menopause before we initiate any therapy? And we need to back up. That's like if we only cared about someone's delivery and we were like prenatal care, like, no, you're totally fine. And then the day they show up to deliver, that's all we do. We're missing the boat. So we now know that there's increasing evidence that the menopausal transition is an independent risk for cardiovascular disease. And the earlier we intervene, the better the outcomes. Again, the clock is ticking. I feel like I should have a like background music going, like a soundtrack or what's it called in a movie? Score. I need a score. Okay. So this slide comes up twice in here because it's very important. I don't care what field you work in, psychiatry, derm, family med, OBGYN, endocrinology. You need to know how the menopausal transition affects the body systems you specialize in. Ortho. So you don't need to memorize all of these things. Know what the menopausal transition does to your patients and believe them when they complain of something. But you'll notice that this burning mouth, taste changes, decreased libido, migraines, this is all over the map because there are estrogen receptors everywhere in the body. In fact, the vagina has the most estrogen receptors. The brain has the second most. Should tell you something. Oh, I love this one. Okay, so no, menopausal hormone therapy cannot solve every problem. In fact, lifestyle medicine probably can. But this is one piece of a very big, complex puzzle. I love this analogy. You can't put gas in this thing and expect it to drive like a Ferrari. So patients will come to you with a myriad of complaints. And they will say, I need hormones. Someone told me I'm in perimenopause or I'm menopausal and I need hormones. And we need to put that in perspective for them and give them realistic expectations. And they can't be this and expect it to speed down the highway. So this is one piece of the puzzle. You still need to address lifestyle with these patients. In fact, you definitely need to address lifestyle. It's also not safe for everyone, but it is safe for almost everyone. Okay, so red light, yellow light, green light. So in the green box, these are people who can have systemic menopausal hormone therapy. And we'll talk about the hormones, but primarily I'm talking about estrogen, progesterone, and testosterone. Yellow is like, oops, I pressed it really hard. There we go. Okay. Press and hold. Yellow is stop, think, maybe look at the details of whatever that diagnosis was. High-risk breast cancer, let's consider that. But these are still people who, in the vast majority of cases, you can find a safe regime for them to be using. And red does not mean you're the gatekeeper and this person can or cannot have estrogen, progesterone, or testosterone. This is stop, think, consult, consent, and then give a buffet, set out a buffet. I guess you're the one behind the buffet, like doing this, but you get to let the patient decide how they want to live their life. Because ultimately, these are like the safest medications I prescribe on a daily basis. So for example, if they have unexplained vaginal bleeding, work that up. Figure out, is it a hypertrophy? Do they have a polyp? Do they have a fibroid? What's going on? Rule out anything super dangerous or estrogen dependent and proceed. If they have uncontrolled hypertension, control it and then choose a transdermal estradiol product. We'll get into bioidenticals versus synthetic, but use a transdermal form so that you don't increase the clot risk at all because you're bypassing the liver. If they have a known clotting disorder, figure out what it is. Some people were begging them to clot. We're like, please, you're gonna bleed out. And use a transdermal if you're concerned about them having additional clot risk. And if they have a history of breast cancer, this is the detailed one. You need to figure out what type, what did they complete their adjuvant therapy? Do they have breasts anymore? Do they have ovaries anymore? My point here is red, the stop category is not a full stop. It's clinical decision making, okay? Okay, so when to start? Do we start people when they're 16? Do we start them when they're 90? When to start? So the timing hypothesis, this initially came out of the Women's Health Initiative. They're like, wait a minute, there's this age group at which people seem to get the most benefits, and maybe later than that, there are more risks. And then there's this years since menopause where people get the greatest benefits, and I'll explain that one. So it's we're 6 and 10. So the benefit here is, or the idea here is that if someone goes more than 10 years since menopause, that is 10 years of no estrogen circulating in their body, which makes all the vessels get really stenotic, and estrogen is very anti-inflammatory, so really stenotic, and all this plaque builds up because of the lack of estrogen, because it prevents plaque buildup. And so they've got this plaque in there. If you add estrogen back into that system, those vessels are going to get all flexible again and start expanding and contracting, and you might dislodge an already existing plaque. So that's the 10-year theory. The age theory just has to do with natural atherosclerosis and the aging of our vessels. But again, not full stops. But 2 RCTs were designed, the KEEPS trial, the ELITE trial. Notice the medications that were used in these. So the first, the KEEPS, well, these are chronologically out of order, but oral conjugated equine estrogen, transdermal estradiol versus just oral estradiol. And basically in the KEEPS, they found minimal benefits, but there were still benefits, no adverse events. Neither formulation had terrible things happen. In the ELITE, even better, oral estradiol, significant reduction in progression of atherosclerosis if it was given at the appropriate time. And there were no benefits when it was given after 10 years since menopause, but those people fared no worse. So that 61-year-old comes in your office, 11 years since menopause, maybe healthy as a horse, maybe suboptimally healthy, maybe healthy as a pony or an ox. And she's like, I am suffering, and here's why. And I'm really worried about my ability to keep my job, my ability to relate with my partner, whatever it is. Think about this and think about risks, benefits, and knowing that she might be 10 years since menopause. She might not get the osteoporotic preventive benefits. She might not get the Alzheimer's preventive benefits, but can you make her quality of life better? Yes. And is she going to fare any worse from a cardiovascular standpoint? No. So in summary of the whole lecture, benefits outweigh risks for almost everyone if this is initiated 10 years since menopause or in women under the age of 60. And there are some pretty cool articles. Look at this. That was like, wait, that was like yesterday? Cool. Okay, so there's some really good new research that says we should start thinking about extending this care past those windows of 10 and 60. When to stop? We used to say years ago, stop everyone at 65, this arbitrary number. We don't say that anymore because as soon as you stop menopausal hormone therapy within 1 to 2 years, you lose all of the benefits you gained. Rapid resorption of bone, rapid decline in cardiovascular health, increased rates of breast cancer, they go through the roof. So there is no arbitrary number. This is an annual evaluation with your patients, looking at their specific risk profile. Maybe now they have a diagnosis of breast cancer. Maybe now they had a blood clot or they've gained a lot of weight and their weight could be contributing to their clotting risk, but there is no arbitrary number. So annually reevaluate this with your patients and decide if they still meet criteria. Okay, so let's talk about the actual hormones. So estrogens, there's a lot of words like estrogens, estradiol, ethinyl estradiol. There's so many different ones. So I'm going to I tried to simplify it for you guys on this slide. And there's a ton of information in here that I recognize you can't just all absorb right now. So you will hopefully be using this kind of as a guide for your practice in the future. So estrogens is a blanket term for both synthetic estrogens and isomolecular. Bioidentical is a marketing term. It was a genius marketing term. After the Women's Health Initiative came out and everyone was terrified of conjugated equine estrogen, which by the way is made of horse's pee, Premarin, pregnant mare's urine. And everyone was like, oh, this stuff is so dangerous, it causes breast cancer. It doesn't, by the way. The compounding pharmacies, custom compounding, they're like, we need to take advantage of this. People are afraid of this product. Let's figure out another product that we can capitalize on. The product already existed. It was just isomolecular estradiol, the molecule shaped the same or is an isomer of the one your body already makes. So they came up with this word bioidentical and called it like custom compounded bioidentical natural hormones. And everyone went crazy. And then everyone got afraid of the synthetic stuff. But I'd prefer not to use that term, at least in this setting, because it is not a medical term. It's not even a scientific term. So isomolecular estrogens, these are the ones that the body naturally makes. Estradiol is the most potent, and this is the one that is most widely used nowadays in hormone replacement therapy or menopausal replacement therapy. There are many synthetics. Ethinyl estradiol, that's what's in most oral contraceptions. Progestogens, there are synthetic progestogens called progestins. There's a lot of these. You probably know some of these names, a lot of them. And then the isomolecular one is progesterone. The product we prescribe is micronized progesterone. That just means it's been made smaller. They just like micronized the molecule. And then testosterone only has an isomolecular formation. Okay, so what we used then. So during the Women's Health Initiative, we used these doses, pay attention, there's a quiz question, of conjugated equine estrogen in one arm of the study. And in the other arm of the study, we used that equine estrogen plus medroxyprogesterone. We don't use these anymore. Well, that's not true. There's a place and time for them, hence this little like caveat here. But for the most part, this isn't where you start. This isn't like step one of prescribing menopausal therapy. It's not to use these. You could graduate to that, maybe next month. But we know that conjugated equine estrogen now has an inflammatory effect on cardiovascular, and MPA has an inflammatory effect on breast tissue. But there is a time and a place for these. So that's what we had then. This is what we have now. We have many, many options for how to deliver these medications into people's bodies depending on their specific risk profile, oral versus transdermal. Oral goes through the liver. Estrogen tells the liver to make more clotting factors. So any oral preparation of an estrogen product is going to increase blood clot risk from baseline. Transdermal does not. It skips that entirely. We've got sprays, capsules, suppositories, rings, patches, everything. So many. Let's talk about uteruses. So you can't just throw a bunch of estrogen into a body. Estrogen's job is to tell the uterine lining to grow, proliferate. I think about it this way. It's like the uterus is a room and estrogen's in there. And estrogen's like this really bad interior decorator, and it's hanging like tapestries and oil paintings and light fixtures, and it's just going crazy. And that's what it would do. It would just cake on a lining inside that room. Progesterone comes into the room and it's like, whoa, pump the brakes. This is awful. What you have done in here is just way too much. And when I leave, I'm taking this all with me. That's a period. That's a bleed. So you got the bad interior decorator that's like going crazy in there. And then progesterone has sense. It's like a really good interior decorator, stops the process and does a mass evacuation of all the garbage that was hung on the walls. So that is like a monthly cycle of stimulation of the endometrium. You always have this balance of estradiol, progesterone. If you were to just throw extra estrogen at that uterus, the interior decorator, no one would tell it to pump the brakes. That is a risk for hypertrophy or cell growth and replication out of control, which is cancer, a risk for cancer. So unopposed estrogen, if a uterus is in there, is a risk for endometrial cancer. It takes months to years to get that way. The interior decorator has a lot of wiggle room there, but still, so a couple weeks is totally fine if someone's just on their estrogen, but that's why we have to add the progesterone back in. So it's really important. This is really, really important when you're doing this, that one of your screening questions initially is like, do you have a uterus? Is it still in your body? And many patients will say they had a hysterectomy and they actually don't know what's still inside their body. I see this every day and I'm like, what's still in there? And they're like, I have no idea. And so then I have to go down, find some records from Indiana from 1998 and figure out what is in there, because I have no idea. Okay. Oh, wait. So if they have a uterus, if they don't have a uterus, sorry, this is important because I think we only talk about progesterone as playing a role in endometrial protection. Progesterone has a lot of other benefits. It helps wonderfully with sleep. It's very anti-anxietal. So it is a really important hormone, but it's kind of like the ugly stepsister in this, and it only gets credit for protecting the endometrium. So even if someone has had a uterine hysterectomy, they still can have progesterone for those other benefits. Okay, common products that provide endometrial protection. There are a ton. You have a lot of different options. Excuse me. I have my dad's nose. Drips. A lot of different options. This would be the bioidentical form or the isomolecular form. And in this, people are probably familiar with this product. I try not to use brand names, but this is Prometrium. It's like a little bath bead. Looks like a little gel, it's a little gel cap. This can go in 3 holes. It can go orally, vaginally, or rectally. It works all the same, and we have excellent data on that. And we'll talk about progesterone intolerance, people who have negative side effects to taking this orally. We have options. We can always hack your hormones. Okay. There's a bunch of synthetic ones. Again, use this sparingly. There's transdermal, that's TD in here formulations. An IUD, a progesterone, well, in this case, it's levonorgestrel containing IUD is an excellent way to tell the uterus to shut up through this whole process so that you and the patient can really focus on the other havoc that is wreaked in the body. So an indwelling local endometrial protection device is a really nice way to gracefully pass through the horrific bleeding of the menopausal transition. This product is so underappreciated. I will tell you the brand name. It's Duavi. Conjugated equine estrogen. Don't let it like sit sour in your brain because it actually does have a lot of benefits. It decreases breast cancer and osteoporosis. Plus beta-doxyphene. This is a SERM. People remember SERMs? They're incredible. Prevent breast cancer, prevent osteoporosis, prevent endometrial cancer, depending on which one you're choosing. This is an option for people who can't take progesterone and maybe have a really high intolerance for it, or who have tons of breakthrough bleeding, because this SERM tells the endometrium to like be quiet, and you don't need a progestogen on this. Okay. Okay, so if you just want to read the article that has every single progestogen and whether or not protects the endometrium, here's the article. You can spend all weekend reading that. I did. Okay, I put this back up here because I wanted to point out some other ones. What do you know? GI issues, GERD. Anyone ever had that? Dry, itchy skin. This is huge. Hair, skin, and nails. This is gigantic. There are estrogen receptors in every skin in our body. It is an organ. Actually, skin makes some of its own estrogen too. Okay, so goals of treatment in menopause. We're going to break this down by menopause and perimenopause. There's nothing specifically unique between the two. There's just a lot more nuance in perimenopause because in menopause, the factory has been shut down. The factories have been shut down. All you're doing is replacing a small dose of that medication or hormone. In perimenopause, oh, we'll get there. I won't even tease you. Okay, so goals are symptom relief, improve quality of life, prevent diseases. This isn't just about helping people sleep better. This is about keeping folks alive longer, decreasing risks of our top deadly diseases for women. This is actually pretty important stuff. And then really importantly, empowering women. 5 years ago, when I told people that I prescribed menopausal hormone therapy, roughly, I don't have a date on when I was at this cocktail party. If I told someone that I did this, they'd be like, oh, what do you do? And I would say women's health, I'm a retired midwife, I do sexual function and menopausal hormone therapy. They'd be like, oh, okay. And then they would turn around and walk away because it was awkward. Now, if someone's like, what do you do? And I say that, they're like, oh my God, I have so many questions. That's so cool. I was following this person on Instagram or whatever. Now folks have permission from our society and our culture to complain about this stuff and to say, no, my quality of life matters. No, I don't want to just sit passively by and become feeble. I want strong bones my entire life. So it's a totally different discussion now than it was 5 years ago. And I think it's because people are getting empowered. Providers are empowered to start learning about this and offering it. Patients are empowered to start asking.